Hi, my name is Alex Vash. I'm the Director of Training for the Sentio Counseling Center. We provide low-fee online therapy and high-quality therapist training and clinical supervisor training. Today's video is on using schema therapy and more specifically the concept of schema modes so that you can work with your complex clients. I want to credit just a few people. I want to credit Joan Farrell and Wendy Bahari for their wonderful resources and books, including the book that we co-authored called Deliberate Practice in Schema Therapy. I also want to credit Drs. Arnst and Jacob for their great book Schema Therapy in Practice, and the psychcollective.com for their wonderful schema therapy resources. And finally, I want to thank the counselors at the Sentio Counseling Center who are present in the lecture you're going to see and who at the end you'll see engaging in a deliberate practice skill building exercise. So I hope you enjoyed the video. Today we're going to be focusing on schema therapy and a particular type of work called schema mode therapy, or focusing on schema modes. Again, if you have any questions as we go along, feel always free to jump in, either in the chat or just jump in, interrupt me. So just a quick recap on something this group has already reviewed in the past 2 weeks. So as you may remember, we've been talking about schemas and early maladaptive schemas. And so just a quick recap. Our early childhood environment interacts with our temperament, and when core childhood needs are partially or not met, or when trauma happens, early maladaptive schemas can develop. Right, so you might remember the core presupposition here is that we all have core emotional needs for safety, for attachment, for limit setting, all the kind of good stuff. And when those needs aren't met, or when like big T trauma happens, we can develop schemas, which are these kind of lingering, painful emotions, like a core sense of sadness or shame or fear, and these kind of rigid, unconditional beliefs, like I'm no good, I'm unlovable, etc. What's important to know, and we're going to kind of add to the schema therapy formulation here, what's important to know is that schemas are traits, meaning they're stable across one's lifespan. So, if I met Terry 5 years ago or 5 years from now, chances are that whatever her schemas are or my schemas are or whoever's schemas are would basically be the same. I mean, they might oscillate a little bit, they might change slightly due to therapy work, for example, but they're basically ingrained, right? They're codified into memory. So we can call schemas a trait-like phenomena. And they're developed in the past, right? I mean, this goes way back to your upbringing, experiences you had with your parent figures or, childhood experiences, etc. What's interesting is that when you go see a client in therapy, or when we as therapists go to therapy, what we're actually seeing in therapy are not our patients' schemas. We can presuppose what their schemas are. We can try to assess what their schemas are. But what we see in therapy is what's called schema modes. So modes are the kind of present tense representation of the client's past coming into the present. So let me be a bit more specific. In the here and now, so you can see this trait-state distinction. The schema is the trait. It doesn't change over time. But every one of us has different parts to them, or you might call them different modes to them. And these are here and now states. And this applies to everyone. It's not like a special type of clients, like borderline personalities or clients have modes. No, all of us have modes. All of us have to cope with painful emotions. All of us have self-critical parts. So this is one of the reasons I like schema therapy and emotion-focused type therapies, is that they're very unshaming. Like every one of us has something like this. And so the three core types of modes or parts that we're always assessing and that will show up during your sessions are what could be called child modes, critic modes, or coping modes. So let's take this rather slowly. But what we now see in the client are not really the schemas. What we see is the representation of the schemas in the here and now, meaning the modes. So because of my training, I use the word modes and parts kind of interchangeably. Maybe schema therapists wouldn't really do that, but when I talk about child modes, critic modes, coping modes, you could also talk about child parts, critic parts, coping parts. And for those of you into Gestalt therapy, emotion-focused therapy, for example, we've talked in the past about the critic parts. Every one of us has a self-critical part, right? That can be really nasty and telling us you're no good, you should be better, what are you doing with your life, etc. That would be called a critic mode. So we can conceptualize a lot of, I would say, I don't want to be extreme, but I think most clinical scenarios you can put into these boxes. Okay, so this is a really powerful formulation tool as a clinician. So we can see that we would call that your client's critic mode. When your client is saying, I'm such a loser, I'm no good, or whatever, that's the here and now state of the client that's being brought up, right? So the critic mode is like the here and now part that's coming up for the client. And it's like they're embodying that part, right? They have an internalized critic and they're voicing that internalized critic. So that's the critic mode. The core really where the pain is what's called the child mode. Some of you may have heard of the expression, the inner child, working on the inner child. A lot of different therapies and therapists use that expression. The child mode is really where the painful primary emotion rests. It's the burdened part. The one that, for example, when the child or the patient was bullied or abandoned or betrayed, it feels sad, alone, betrayed, maybe angry, maybe ashamed. So the child mode is where the primary emotions sit. Okay? And remember, the reason why we value emotional work and we want to go into primary emotions, that emotions have a biological reason to exist. Emotions tell you what your clients need, right? So we need to access our client's child mode or vulnerable child mode or primary emotion, whatever you want to call it. We need to access that in order to understand what they need to feel better. So if you have a scared child mode, meaning the client inside sometimes feels like a scared child, even though they may be 50 years old, that scared child needs safety, needs a visceral feeling of security, which is something you can provide through corrective experiences in therapy. So the child mode is really the core of effective therapy, being able to access that primary vulnerable emotion, and providing corrective experiences for that vulnerable, tender primary emotion. Now, what often happens is you don't actually see the child mode. I mean, some clients will come in and they're quite vulnerable emotionally. They'll share in a very transparent way. They can access their emotions. And so you start with their child modes, but actually most clients do not come in this state. Most, or at least many of our clients come in what we may call their coping mode or their coping part. And these are any parts that are trying to not experience emotions. They are trying to help manage the painful emotions that are burdening the child mode. So again, to make it more concrete, let's imagine a patient who has a really scared child part because they were abused by a parent. Right? So they learn through that experience that they can't trust others, and they have this core sense of fear. No one can really survive being in a core sense of fear for too long. So instead of seeing the child mode, what you're mostly seeing is the patient's coping mode, which is the part that's trying not to feel or not express feelings. Now, there are many different types of coping modes, and we'll get to that in a minute, but this is a very crucial point. The crucial point is that when you're in therapy, in most cases, you're either going to be dialoguing with a client that's in child mode, critic mode, or coping mode. And this is a cool thing you can actually try with your videotapes, with your video recordings of sessions, is just go into your video recording, pick out a moment of a video with your client where you're struggling with, and just try to see, is this client more in touch with their kind of visceral primary emotions? So they're more in their child mode? or are in this kind of punitive, demanding, critical voice. So they would be in their critic mode. Or are they kind of trying to detach or overcompensate or soothe or basically not experience the painful emotions, right? And that would be the coping mode. And again, a lot of clients will come into therapy in coping modes. And of course, the problem with that is that if the client is stuck in this coping mode, it might work to a certain extent, but you can't really access both what they need and how they could be in a better relationship, for example, if it's the case of couples therapy. So this is the point of this kind of parts language or mode talk, is that his clients are cycling through child modes, coping modes, critic modes without being able to really stay with the child mode and get corrective experiences. Their adult needs are not met and or negative consequences occur. Another example, if my child mode is of a primary shame, let's imagine, because I was maybe bullied or rejected early on. And so my primary child mode is one of being ashamed, right? And I carry that along with me. But what you see in session is an overcompensation of that, where I'm actually full of bravado and actually I'm not ashamed, I'm the best. So it's a narcissistic overcompensating coping mode. That might work, quote unquote, for certain circumstances, but it doesn't really change the fact that underneath, I'm still like an afraid, ashamed child. So I can't really stay with that shame and transform it. It's like I'm always running away from my own feelings. So my core needs are never really met because my life is a perpetual running away from my core experience. Vanessa, you're asking, are these modes always caused by a child's attachment with a caregiver, or can it also come from a relationship with a best friend? Wonderful question. I was actually, when I started doing this kind of work, and also I did a personal psychoanalysis many years ago when I was a teenager, I was kind of frustrated because it seemed like it was always the parents. And to be fair, most cases are. Like most cases at least start with a vulnerability that was constructed through the caregiver, but not always. You are totally right. Sometimes you do have a safe enough, good enough attachment with a caregiver, but then as you go, for example, into your teenage years, you have experience after experience of rejection with very close either friends or romantic partners, and that can also consolidate some schemas. So here's an even more kind of bigger summary of this map, and don't be scared. It looks a lot, but it's actually quite simple. This is just another representation of these three boxes we just saw: child mode, coping mode, critic modes. So if you look down at the bottom, which is the core emotional experience of your patients and of ourselves as well, we have a vulnerable child mode that has the primary emotions, and what's also called an angry child mode, which is basically kind of yelling and shouting like a tantrum because we're not getting our needs met. So this is the more like baseline layer, emotional layer of all of us, including our patients. And then there are all these layers of coping modes or coping parts to manage the vulnerable child and the angry child. So we try to cope with our emotions, with our vulnerable child mode, by freezing, what's called the compliance surrender mode. These are all variations of different types of coping modes, okay? So the freeze mode would be basically saying that they basically believe or agree with the schema. So if the schema is I'm not good enough, the freeze mode just says, you're right, I'm not good enough. So they just kind of give up and they just assume the schema is true. And you see this a lot in like depressive type clients. So that's one way of trying to cope with the painful emotions, is just kind of giving up and freezing. Most often what you'll see is flight coping modes, which is trying to avoid emotion altogether. So these are avoidant protector modes, angry protector modes, detached protector modes. These are all slight variations for the same thing, which is a part that's trying to help you not feel your feelings. So let's imagine your client comes in and they're really kind of flat affected, right? You don't see any emotion. They talk very cognitively. It's all very intellectual. This is all a variation of the flight coping mode. And a lot of times you're going to be working with a detached protector mode, because a detached protector is the part that wants you not to feel or not to feel feelings. And we can do some work around, some experiential work around that particular mode of your client. With a lot of anxiety disorders, you'll see a lot of avoidant protectors as well, which is a part of the client that basically says, don't go into that anxiety producing thing. So if your client has, for example, social anxiety disorder, the avoidant protector will say, don't go to parties, don't socialize, because that will trigger this vulnerable child, this scared or ashamed vulnerable child. So just avoid it altogether. It's also a cool way to conceptualize different therapy models. Like, what are you doing in straight up CBT when you're doing exposure work? When you're doing exposure work is you're trying to help decrease the prevalence of the avoidant protector, for example. This part that says, don't go into the stressful thing, you're addressing it through the exposure and trying to create mastery experiences so that instead of feeling primary fear in a stressful situation, I feel mastery, I feel safety, I feel confidence, right? So these three layers are three layers of coping modes. We could go into a lot of detail here. For example, you can also manage your own emotions by self-aggrandizing. These are the fight coping modes. And this is what you see in narcissistic personality disorder. So underlying any narcissist, there's actually usually an ashamed child mode, but they're trying to overcompensate that internalized shame by, being self-aggrandizing. In OCD clients, you'll see an over-controller part. And why is that? Because the OCD client underneath has this core sense of fear, a vulnerable, fearful child mode. So in order to deal with that core fear, they overcompensate. And they overcompensate by trying to over-control the situation or the relationships, etc. Right? So these are all variations of coping modes. And then these two things here are the punitive parent and demanding parent mode are variations of critic modes, parts that have been internalized that are basically saying you're not good enough, you should be able to do more or to do better. And for the September cohort, we already did a lot of work on unfinished business and chair work for self-critical voices. This is where that comes in. If you see a client that's super punitive, you want to first bring awareness to that punitive voice and then work with it directly. All of this is helping develop the healthy adult mode, which is the part of us that helps us meet our needs in an adult manner, and what you may call the happy child mode. And it's funny because when you start looking at psychological functioning in this way, you can track your own modes as they happen in the here and now. So for example, when I'm playing guitar with my friends, I can feel a happy child kind of really happy around it and spontaneously having fun about it. That's a core happy child mode, right? Or when I set a boundary in order to meet my own needs, that's my healthy adult mode. But if I start detaching too much from emotions, avoiding too much stressful situations, that's a coping mode. And by the way, coping modes are trying to protect us, right? So they're not bad, but the problem with coping modes or with overusing coping modes, again, is that if we can only deal with our emotions through the coping modes, the problem is that our needs will not be met most of the times. It's good enough to not feel emotions, so it regulates us a little bit, but it keeps us needy. Let me just go to the chat here. Oh, thank you, Natalie. Yes, so the image we just have here is from the psychcollective.com, which I believe it's an Australian group, which is really great. And the resources are really good for schema therapy. And I also want to give props to Joan Farrell, who wrote this book called Experiencing Schema Therapy from the Inside Out. And it's kind of a self-therapy schema therapy book where therapists can use schema therapy on themselves. It's a really nice book. If you want to learn more about it, send me an email. I'm happy to send you some stuff around it. And this particular map is I adapted from that book. And Joan Farrell was also the lead author in the book that Tony and I co-wrote with her on deliberate practice for schema therapy. So we're all in good company here. So this is just the last slide I wanted to show you, just to give you kind of this model in a 3-step way. So again, let's just take it step by step. Childhood environment interacts with your temperament. When childhood needs aren't met, we can develop maladaptive schemas. And now, in the present moment, you see those schemas acting up mainly in these three parts or modes that all of us carry: child mode, critic mode, coping mode. You can go into a lot of detail. We won't go today into a lot of detail to the different coping modes, etc. But there's different types of experiential, cognitive, and behavioral work that you can do for each of these. Okay, for the critical parts, for the coping part, for the vulnerable child parts. It's a very powerful formulation map. And it's a very powerful formulation map because it tells you also very clearly what you need to do for each part. And this is just the last little thing I wanted to leave you with in terms of theory. So strategically, once you assess your client's different modes or parts, you also get a sense for what they need, well, for the kind of therapy work you need to do for each part. So starting with the child mode, that primary mode, the overarching goal that you have in therapy is to validate the emotions and unmet needs of that child mode. That's the first one. So if this child mode, if this person has a child mode that's like ashamed, you want to validate their experience, normalize it, go deeper into it, and this is the kicker, provide corrective experiences that try to undo that toxic shame, right? So that's for the child mode. For dysfunctional parent modes or critic modes, we can use the term interchangeably, dysfunctional parent modes or critic modes. Back to Vanessa's question, I prefer the term critic modes because not all critic modes have to do with parents, although most do, not all do. What you do with these critic modes is you try to question them and set limits to these critical voices. And you can do that in share work. You can do that with cognitive and behavioral work. There's a lot of different ways where you can counterattack your critical voice. And for all the coping modes, overcompensating coping modes, avoidance and surrendering coping modes, all those little things we just saw, there's a lot of strategies we can use, but the basic ones is to confront empathically. By confronting empathically, we mean, on the one hand, saying it makes sense that you're trying to cope with your emotions in this way. I guess it worked to a certain extent in the past, but it's also leaving you needy. It's not really working that well. Right? So that's what's called empathic confrontation. And you might be happy to know that our next training will be exactly on this topic of empathic confrontation, because it's such an important skill that you'll need for so many of your clients. You can validate the existence of the coping mode. You can discuss the pros and cons of having that coping mode and try to set limits to them. And while you're doing all this, what you're really doing is you're strengthening in every way the healthy adult mode, the part of us that is able to stay with our feelings, be regulated, and act in a way in accordance to our needs. So I know that's a lot of information, but we're going to go back again and again to these maps, because once we have these maps, now we can formulate so much stuff with them, okay? So feel free to kind of go back to them. If you want more reading materials on these concepts, just drop me an email. I'm happy to send it to you. But let's make this even more concrete clinically. Let's do a small deliberate practice exercise. And let's do it together, okay? Now, what I'm going to ask is that all of you in the chat, write on the chat. I'll explain in a minute what you need to do. So this is a deliberate practice exercise from our deliberate practice book that just came out a few months ago, Deliberate Practice in Schema Therapy. So Joan Farrell was the main author, and Wendy Bahari. And just to get us started, let's not even write therapist responses yet. Let's just do it as a form of kind of assessment skill. So what you need to do is to write on the chat, as I read the client statement, write on the chat if what you're seeing is a critical part, a coping or protector part, or a vulnerable child part. Now, the client statement can have more than one, okay? Usually they'll have one or two of the parts they're presented, okay? So let's try it together. So the client says, I finally went to work out this week. It felt kind of good, but I also think I looked really, really stupid while working out. So I'm curious, if you could put on the chat, what part do you think might be coming up here? Okay, we got 100% success rate here. Everyone on the chat is writing critical part, and you are totally right. And Daniel, I enjoy your precision. You are saying critical slash vulnerable because yes, there's something there that could be perceived as like a vulnerable part. What is coming up, like the problematic part that's coming up, is the critical. That's what's coming to the forefront, right? So that makes total sense that you can see both. And David, yes, do you want to say a bit more about the healthy adult slash child mode?
I'm just saying it felt kind of good. So there's some acknowledgement of maybe there's a little joy in that or a little pleasure in that, or self praise for doing something that is in line with the values. And it's not really enough for me to put much on it, but there's something there, something positive.
I really appreciate, yeah, I really appreciate you saying that because it also speaks to a complexity here, which is most parts, if the client isn't super disturbed and totally fixated on just one part, you'll find inklings of a lot of different parts in most of your clients, right? Like most clients are just like embodying a critical part or just embodying a coping part. Some very complex clients are, but most aren't. So you'll be able to parse out, well, there's a critical part, but there's also a coping part and maybe a vulnerable, maybe a healthy part. So for the purpose of this exercise, let's try to track what seems to be at the forefront coming up that could be a focus for work in therapy. So that also helps me clarify my original question. All right, great work. Now, what's a reflection that we could do here for this client statement in an actual therapy session? And I'll just give you an example and then we'll actually try it out ourselves. So the therapist here so the task here in clinical practice is to reflect what the client just expressed using schema modes language. So the therapist could say, I see, it sounds like you have this really critical part of you, and it was saying you looked really stupid while working out. Okay? So you're picking up on this problematic part that's coming up. And notice there's no jargon involved, right? I mean, you could put jargon if you wanted. You could say, well, there's this thing called the schema mode. And, because of your early maladaptive schemas, now the schema mode is being activated. You could go into all that. But frankly, I think day-to-day normal speaking for most cases is just better. So we can just say, there's this critical part of you. Jeffrey Young, the inventor of schema therapy, often uses the expression, it's like a tape going through your head that's just saying nasty things to you, right? So this idea that there's like a voice in your head that's telling you nasty things, that's you pinpointing a part, right? Let's try another one. So client says, I'm not sure why, but when my partner started talking to our mutual friend, I get really jealous. So try in the chat, what are the parts you're seeing here? Or part. Great. Okay, so most of you are writing vulnerable, right? A few of you have written vulnerable slash coping. Natalie, for example, do you want to say a bit more? Because you wrote vulnerable slash coping.
Yeah, so how the client says, I get really jealous. So jealousy can be a coping mechanism for them to feel better about themselves. So they put a wall.
Right. It could be the case. We would need more information to figure out if it was a coping mode. I'll tell you, my kind of go-to would be saying primarily it's a vulnerable, kind of fearful child part, right? And then we would have to assess how does the client manage that insecurity or that jealousy. And through there, you'd be able to parse out their coping mode. And you know what's fun? We can go back here. Different people would cope with that jealousy in many different ways, right? Some would just detach, not think about it, and that would be a detached protector mode. Some would be blaming and attacking. That would be a bully attack mode. Some would try to control the partner. You can't go out with your friend. That would be an over-controller coping mode. So there's all these different coping modes that are specific to our clients. And what's important is that we assess their specific ways of coping with their vulnerable child mode. Great. Now, I'm going to ask, I'm just going to go randomly here. Sasha, would you do me the honor? Do you want to try giving a therapist response here? So client says, I'm not sure why, but when I see my partner talking to our mutual friend, I get really jealous. You're going to try making a reflection that just highlights this part that might be coming up.
Okay, I can do that. May you read it one more time, please?
Yeah. I'm not sure why, but when I see my partner talking to our mutual friend, I get really jealous.
It sounds as if there's this part of you that may be fearful of, that kind of interaction that your partner's having with that friend. What's going on with you when this comes up, when you feel this jealousy?
Beautiful. And is okay. I'll give you just a small tweak there. I love that you focused in on that insecurity, that jealous part, right? So there's a trigger, right? The partner talking to a mutual friend. And you could say something like, so when the partner talks to your mutual friend, there's like this vulnerable part that feels insecure, right? So you're kind of inserting that language of there's this part of you, it might be hard to access, or maybe it's very easy to access, I don't know, but there's this part of you that feels this insecurity. Do you notice that as well? Right? Does that make sense, Sasha?
It does. That was good. Thank you.
Cool. Using parts language, or in general parts language, most clients really enjoy it, and it helps them understand their own problems in a new light. So it can be really helpful. So an example response here would be the therapist saying, so for some reason, there's a vulnerable part of you that feels really insecure when your partner talks to other people. Is that it? Be one example. Okay, let's try it another one. And again, feel free to write on the chat what parts might be coming up. Client says, I'm so stupid for not having accomplished more in my life. I feel so ashamed. Oh my God, we have a bunch of schema therapists already in the making. Amazing. Okay, great. So the correct answer, a lot of you wrote, was critical and then vulnerable, right? So that's the sequence that's going on here. There's a critical part of the client, a critical voice that's saying you're so stupid for not having accomplished more. And then there's the part that feels criticized, right? That feels ashamed for that. If we go back to our map here, again, the critical mode here says you're stupid, you should have accomplished more, etc. And then the child mode reacts to that. It's like an inner conversation going on, right? There's a part that's shaming and punitive and critical, and then another part of us that feels the shame, feels the criticism, right? So if we go back to our thing here, Terry, would you like to try giving a therapist response?
Sure. So it sounds like you're having this really critical part of you, and you feel like you should have accomplished more in your life, which is causing you to feel ashamed.
Beautiful. Now just tweak that last part, which then triggers this other part, a part that feels really ashamed, right? So you want to insert the language. There are two parts here. It's like there's two parts here. There's a part that feels really critical, right? A part that's telling you you're stupid. And then there's another part that feels really ashamed. What is helpful is to be very clear. There's two different parts there, right? So we want to be very clear so that you can work with them independently. So for example, so a part of you really criticizes you for not having achieved more. And then another vulnerable part feels really inadequate and ashamed. And the cool thing about this is a learning point for everyone, is that then you can do therapy to help both parts. You can do therapy to combat the self-critical part and fight it back. And you can do therapy to meet the needs of this vulnerable, ashamed part. Right? So there are strategic therapy goals for each part. Great work. Thank you so much. I know it's not easy to improvise responses on the fly, and I'm really appreciating the work. Let's just do one more. One or two more. So client says, I feel really sad and alone at work yesterday. I felt really sad and alone at work yesterday. Like I had no one in the world to help me. When I feel like this, I just want to give up my job. Again, try seeing which parts are here. Beautiful. Again, so many schema therapists in the room. You're absolutely right. So there's a vulnerable part that feels the sadness and the aloneness, right? Probably because, they grew up in a certain environment that consolidated that schema. So there's a child mode that feels that way, the sadness and the aloneness. And now it's coming up in the present moment, right? And then this coping part comes in and tries to manage that sadness and aloneness, right? Tries to help you not feel the sadness and aloneness. I'll just try. Bill, would you be up for trying reflection here?
Sure. Are you going to read it or am I just going?
Let me read it. It might be better. Okay, so I felt really sad and alone at work yesterday, like I had no one in the world to help me. When I feel like this, I just want to give up my job.
Oh, Alex, so it sounds like you've got this really vulnerable part of you that feels the sadness and feeling alone. And you also have this other part, coping part, that just wants to give up or run away. Is that right?
Amazing. Totally right. I'll just read another example response, but yours was perfect. I'm sorry to hear that. It sounds like there's this tender, vulnerable part of you that feels really alone. And then another part of you that's trying to help you cope with this by suggesting you could just give up. Does that make sense? Great. Wonderful.